Welcome to the ATS Society webinar on the new and revised codes for 2013. The webinar will cover pediatric polysomnograms, review pulmonary function test codes, and forced exhaled nitric oxide monitoring codes. I'm Gary Ewart, and I'll be moderating today's call. Our presenter today is Dr. Scott Maneker. Dr. Maneker is a member of the American Thoracic Society Clinical Practice Committee and has also served as the AMA RUC and CPT representative for the American Thoracic Society. He's also recognized as an expert on coding, billing, and regulatory compliance issues. Dr. Maneker is an associate professor of medicine and pharmacology at the University of Pennsylvania Health Systems. With that brief introduction, I now turn over to Dr. Maneker.
Thank you, Gary. It's really a pleasure to be re-recording this for you today for the Thoracic Society members. I'm always delighted to talk about billing and coding, and in particular bring this update on some recent changes to both pulmonary function and sleep testing codes that have occurred over the past 2 years. I've been very honored to serve the Thoracic Society as well as several other societies in the reimbursement arena, if you will, for both the CPT and relative value unit processes. I also serve on a CMS Federal Advisory Committee, the Hospital Outpatient Panel, and on our local Medicare Contractors Physician Advisory Committee. Next slide, please. Although I serve on all these committees, frequently advocate and represent for many societies and work here at the University of Pennsylvania, the opinions I'll be providing today represent my own, not representing any of those other entities today. I will be doing my best to give everybody the routine, correct instructions, knowing what we know about Medicare's policies. However, it's very important, and we'll have several opportunities to talk about this later through the course of the talk. It's very important to recognize that individual Medicare contractors can, to a certain extent, set their own rules. And once we move to the private payer arena, there are all sorts of opportunities for them to set their own rules. So I'm going to try and give everyone a level playing field, if you will, with an interpretation and an approach to Medicare's payment policies regarding these CPT codes. But everyone needs to recognize that other payers will have their own different rules, as we'll see later through the talk. And I have the routine disclaimers there for things that I've done not only in the past 1 or 2 years, but over the past 10 or 15 years in full disclosure to the members. Next slide, please. I think everybody on the call will be very familiar with the routine measurements of pulmonary function, including the flow sensing spirometer shown here. The next slide gives a sample spirogram, which is the typical output from these studies. In addition, there are other outputs, such as flow volume loops, and of course data tables full of the important information that we use to interpret pulmonary function tests. Spirometry is usually not performed in a vacuum by pulmonary physicians. Next slide. They'll typically be interested in lung volumes, and of course there are 2 different general methods for determining lung volumes. The first and probably more common would be body plethysmography. Shown on the next slide is a body plethysmograph, one of several that are out there on the market. There is a second technique for directly measuring lung volumes, namely gas dilution with helium and nitrogen mixes. Next slide. The third typical pulmonary function test that we as pulmonologists would typically be ordering is, of course, the diffusing capacity shown here, where one does a simple breath hold maneuver for 10 seconds, and then we calculate from the uptake of carbon monoxide the diffusing capacity. Next slide. And then we do a lot of calculations and try and make a determination in accord with the interpretive guidelines put forth by the ATS in collaboration with the European Respiratory Society, shown on the next slide. We make a specific diagnosis, and by interpreting these values for spirometry, lung volumes, and diffusing capacity, we can come up with some general idea category of diseases that the patient might have. Now, part of the reason that we have new pulmonary function codes can easily be summarized from this 2-minute discussion and refresher of everybody of the approach to pulmonary function testing. Pulmonologists typically don't order spirometry alone. They would order spirometry along with lung volumes and/or a diffusing capacity. In contrast, primary care physicians typically not only order but often perform spirometry. And so there's a very large universe of spirometry performed alone. But the majority of lung volumes and diffusing capacity were performed together with some form of spirometry, typically ordered and requested by pulmonary physicians. Therefore, the Thoracic Society and College of Chest Physicians were asked to revise the pulmonary function testing codes to account for this far more common method of ordering lung volumes and diffusing capacity at the time of spirometry. Next slide. So CMS made this request of us because more than 75% of the time lung volumes and/or diffusing capacity were ordered with spirometry. So they requested that we delete the previously existing plethysmography codes, which actually were not in the pulmonary function testing portion of the CPT manual, but since plethysmography was deemed a cardiovascular test, it was actually placed in the cardiovascular section in the 93,000 series of CPT. These 3 are among the 10 codes deleted from CPT. Next slide. Many of these other lung volumes, in addition to the diffusing capacity, were also deleted. We need to recognize that there was a great deal of confusion for many, many years with these various lung volume CPT codes because, as I mentioned before, they could be reported by either of 2 methods. Some Medicare contractors, as well as many different private payers, had all sorts of rules out there. Some allowed reporting of 2, 3, 5 of these lung volume measurement codes at the same time, and others prohibited certain combinations or more than a certain number of codes. So it was confusing for payers and confusing for pulmonary function labs as well. So this did provide us an opportunity to try and simplify the reporting of lung volume measurements. In addition, one of the 2 codes deleted, the 94725, has virtually no clinical utility, yet it was billed 100,000 times a year to the Medicare program, paid out over $6 million each year, with no good clinical rationale for that test rather than the standard diffusing capacity maneuver reported with the 94720 that we're all very well familiar with. So again, this provided an opportunity to clean up errors and misunderstandings and confusion with regard to pulmonary function testing. Next slide, please. So we added 4 codes. We added 1 code for any and all lung volume measurements obtained during plethysmography, a completely separate code for not only lung volume measurements, but all the other types of pulmonary function measurements one might make using a gas dilution testing paradigm. Since one can obtain an airway resistance measurement by body plethysmography, but not any of the gas dilution methods, we needed to allow the opportunity for airway resistance by oscillometry. And then finally, we needed to have a single code reflecting performing diffusing capacity. Next slide. So let's go through these in sequence. The prior trio of body plethysmography codes, 93720, 21, and 22, reflecting respectively the complete study, the technical portion only, or the professional component, have all disappeared in favor of the new code 94726, body plethysmography determining lung volumes. And if one were to divide up the technical reporting from the professional fee, it would follow the standard addition of the modifiers TC for the technical component, 94726-TC, And the professional fee for doing the interpretation would be 94726-26 in accord and in parallel with all of the other standard typical pulmonary function tests. Next slide. Now, for the measurement of lung volumes, there are two new codes. Body plethysmography is now the 94726, and that would account for measuring thoracic gas volume, functional residual capacity, calculation of the residual volume, and total lung capacity, all of the standard lung volume measurements that one can make doing plethysmography. You'll notice in the lighter green box that the 94726 plethysmography code now includes the airway resistance measurement formerly reported with 94360. So that valuation, if you will, is now part and parcel of body plethysmography. For the gas dilution techniques of measuring lung volume measurements, one would report 94727, and of course that would not include an airway resistance measurement, since one cannot calculate an airway resistance measurement using the gas dilution techniques. So with the deletion of the 94360, we still needed to account for the opportunity to measure airway resistance using an oscillometric technique, recognizing that there were several techniques, the most common of which is, of course, impulse oscillometry. But there are other oscillometric methods of determining airway resistance. To accommodate that possibility, we have the 94728 airway resistance by impulse oscillometry. Then, as I mentioned before, the standard diffusing capacity maneuver along with the membrane diffusion test were discarded in favor of the new 94729 diffusing capacity. I want to note for the listeners that the 94729 diffusing capacity cannot be reported alone. It is an add-on code and must be reported in the context of a base code. That base code can be either spirometry or any of the lung volume measurements, 94726 or 94727. Next slide. So to just briefly review, plethysmography can determine the usual lung volumes and airway resistance. In contrast, helium dilution and nitrogen washout methods can be used to measure the standard lung volumes. Although you cannot measure an airway resistance, you can use these techniques to make measurements of the distribution of ventilation or to determine an airway closing volume. All of these different measurements would be subsumed within the helium dilution and nitrogen washout methods. And you need not do all of these tests or all of these calculations when you are performing the gas dilution techniques. Only the measurements that you are clinically interested in that are medically necessary for the care of the patient. Next slide. Spirometry can still be reported alone by both primary care physicians and pulmonary specialists. So of course, body plethysmography can be reported with any of the standard spirometry studies that are done, be they spirometry alone, the 94010, spirometry before and after a bronchodilator, the 94060, or a bronchoprovocation challenge testing, 94070. And as I mentioned before, diffusing capacity can certainly be reported with plethysmography alone. Next slide. One would not report gas dilution. They're mutually exclusive. So if you're measuring lung volumes by plethysmography, you would not perform gas dilution. And then similarly, as you'll see in the subsequent slides, for performing gas dilution, one would not perform plethysmography. Similarly, one is not allowed to report airway resistance by oscillometry because if the patient can perform the maneuvers for lung volumes, they should be able to perform the maneuvers for airway resistance doing plethysmography. Next slide. Conversely, or rather similarly, if one's performing lung volume measurements or any of these other measurements, such as the distribution of ventilation or determination of a closing volume, one can report the gas dilution techniques with the same 3 spirometry codes or diffusing capacity. Next slide. And in parallel, if one is reporting gas dilution techniques, one does not simultaneously report body plethysmography. Next slide. All right, now here's a picture of a child performing oscillometry to determine airway resistance. For whatever reason, the patient is unable to perform the maneuvers to determine airway resistance with body plethysmography, and therefore airway resistance can be determined with an oscillometric technique. In the limited extent that the patient can still perform a diffusing capacity maneuver, that is allowed with airway resistance measurements by oscillometry. Next slide. This is an example to show that there's a very good concordance between airway resistance measured by spirometry compared to airway resistance measured by impulse oscillometry. The airway resistances are similar, as are the resonant frequency changes and the other calculated measurements determined by oscillometry. This particular study showed that one obtained similar results whether bronchoconstriction was obtained by exercise at room temperature or cold temperature. Next slide. As mentioned before, if one is reporting airway resistance by impulse oscillometry, the assumption is that the patient cannot perform spirometry and similarly cannot perform plethysmography, and therefore the 3 routine spirometry studies, 94010, 060, or 070, as well as the flow volume loop, would be prohibited. Next slide. As mentioned earlier, the diffusing capacity is now an add-on test and requires a base code. Here's a list of any of these 7 pulmonary function studies, either spirometry or lung volume measurements or airway resistance by oscillometry, can serve as the base study for the add-on diffusing capacity code. Next slide. This is the best visual description that I could try and come up with for people to visually understand how to be reporting pulmonary function testing. The size of each of the ovals in front of you reflects the volume of the original studies billed for plethysmography, gas dilution, spirometry, and diffusing capacity to Medicare back in 2009. The largest is, of course, reflecting all the different spirometry techniques. The smaller ones reflect the lung volume techniques and the diffusing capacity, and the smallest would be the airway resistance. From the overlap of the ovals, one can see that the lung volume measurements by either plethysmography or gas dilution, 94726, 94727, can be billed with spirometry. One can also visually see that the diffusing capacity, 94729, can be billed in addition to either of the lung volume measurement techniques or spirometry. And of course, impulse oscillometry, 94728, can serve as the base code for the diffusing capacity maneuver, 94729, or can be billed in addition to the 94727, the gas dilution techniques, to the extent the patient can proceed with those measurements. Next slide. The CPT instructions for calendar 2012 and 2013 included some additional specific instructions that correspond to Medicare's National Correct Coding Initiative edits, preventing component codes from being billed with each other. Naturally, spirometry would be all-encompassing, and so the components such as a vital capacity or flow volume loop would not be billed in addition to spirometry. These are all components of spirometry. Similarly, a maximal breathing capacity maneuver or a maximal voluntary ventilation would be included with spirometry just as a vital capacity. Next slide. The bronchial provocation study similarly now includes all of the components of spirometry. And likewise, one would not be reporting a maximum breathing maneuver, a flow volume loop, or an airway resistance in the context of performing a bronchial provocation test. Next slide. Similarly, the vital capacity is now clearly instructed to be considered a component code and bundled in to each of these studies. Next slide. Same for the maximal breathing maneuver or maximum voluntary ventilation. Next slide. Now, the flow volume loop is considered a component code of spirometry, and pretty much all of the commercial spirometers on the market will give you the opportunity to take a quick look at the flow volume loop, and therefore the flow volume loop is considered a component of spirometry. Next slide. We are frequently asked, why isn't nitric oxide covered? And to the credit of the American Thoracic Society and the College of Chest Physicians and other participants, we requested and were granted a specific CPT code for the measurement of nitric oxide as a measure of airway inflammation, typically in patients with asthma. That CPT code was granted and became effective on January 1st, 2007. And as we sit here having this webinar in December of 2012, Medicare doesn't recognize any physician work with 0 RVUs for physician work, but recognizes 1/100th of an RVU for the malpractice expense and 59/100ths of an RVU for the practice expense or technical component of performing exhaled nitric oxide measurements, with a total reimbursement just over $20. Next slide, please. However, there aren't very many Medicare patients with asthma in whom exhaled nitric oxide is being reported and billed to Medicare. In contrast, many other private payers, third-party payers, who have large populations of young asthmatics in whom exhaled nitric oxide might very well be clinically useful, have specific coverage policies excluding payment. I give only 2 examples here. I give the example of the Cigna policy, considering exhaled nitric oxide experimental, investigational, or unproven. And similarly, 2 health plans in Nevada consider exhaled nitric oxide measurements not medically necessary to diagnose or manage asthma. So many third-party and private and commercial payers will not recognize claims for this service. But Medicare, as shown on the next slide, has recognized this code since 2007 and continues to pay for this code as appropriate and medically necessary for Medicare beneficiaries with asthma. You can see from the several hundred studies billed to Medicare in the first year the code existed in 2007. In calendar 2011, the most recent year for which claims data were available, around 11,000 of these studies were billed to the Medicare program. So for those on the call who are interested in exhaled nitric oxide, I can assure you that the Medicare program recognizes and pays claims for medically necessary, clinically appropriate exhaled nitric oxide measurements, but there are many payers, other payers out there who do not. Next slide. I'm going to shift gears for the next 5 to 10 minutes of the webinar before we open it up for questions and talk about some new sleep medicine codes. The 2 new sleep medicine codes are specifically dedicated to testing the pediatric population for sleep-disordered breathing. And the creation of those 2 codes required some additional modifications in the language for the adult codes. So what you see before you are some slight revisions to the introductory language in CPT for sleep testing. since children sleep more than adults, they have a longer mandatory sleep recording time. And this language specifies that for the pediatric population, one needs to have at least 7 hours of recording. Anything less than 7 hours of recording would be an incomplete study and need to be reported with a modifier 52. Similarly, the adult studies have that same requirement with an inadequate recording time, but it is maintained at 6 hours. Next slide. This 6-year cutoff for the pediatric sleep studies required changes in the age requirements for the adult studies. So all of the adult in-lab studies now specify age 6 years or older. And for limited sleep studies, there's no specific dedicated pediatric code, and therefore all the age ranges are bundled into the, or grouped into the 95808 polysomnography with sleep staging and only up to three additional parameters rather than a full sleep study with 4 or more additional parameters. Next slide. Here are the 2 new pediatric sleep codes. The 95782 is a standard sleep study in any child up to age 6. At age 6, one would then be using the adult codes. It's a standard sleep study with sleep staging in addition to 4 or more additional parameters, and it's an in-lab attended study. This is directly akin to the adult 95810 sleep study. The parallel to the adult 95811 CPAP titration study is this new pediatric sleep code 95873, which includes not only sleep staging, but additional initiation or titration of positive airway pressure. Next slide. As we will see in a slide or so, there's a higher valuation for the studies in children than in adults. This is for several reasons. As I mentioned before, children sleep longer than adults. The typical sleep hours are longer, and therefore the mandatory recording time is a full hour longer, 7 hours for children as opposed to the 6-hour minimum recording time for adults. Children have many more hypopneas rather than true apneas, which are slightly more difficult to detect. They have far more movement artifacts, and typically pediatric studies include an extra channel dedicated for end-tidal or breath carbon dioxide measurements. Finally, because of the unique nature of children with their frequent movements, hypopneas, and technical difficulties, these studies are typically and most characteristically performed in a 1-to-1 technician-to-child ratio. So 1 technician for 1 pediatric patient, in contrast to the adult population, where it's far more typical for a single technician to be monitoring 2 concurrent adult sleep studies. Next slide. As I mentioned, here are the work and practice expense RVUs for the 2 new pediatric studies. The work RVUs are slightly higher. The 95782 and at 2.6 RVUs corresponds to 2.5 RVUs for the 95810 adult study. The 95783, the pediatric CPAP titration study, has 2.83 work RVUs in contrast to the 2.6 RVUs for the 95811 adult CPAP titration study. But regardless of those slight hundredths of an RVU difference, one will notice that the practice expense RVUs for these 2 pediatric studies are almost 50% higher than for the adult studies. And that reflects the 1-to-1 technician ratio rather than the 1-to-2 technician-to-patient ratio characteristic of adults. At the time this recording was originally made, we did not know what the final payment would be, but it was estimated to be around $1,000 to $1,100 for the pediatric studies, representing several hundreds of dollars higher than the adult studies. Next slide. Next slide. There we go. For those of you who are, of course, not sleep physicians, the sleep doctors will recognize this immediately, but here's a typical sleep study representing quiet sleep. And one can see on the left-hand side, right below the electrocardiogram and snoring channels, the end-tidal and transcutaneous CO2 measurements that are, in fact, characteristic of the pediatric sleep codes. In contrast, on the next slide, the sleep physicians will recognize a child who is awake from the tracings shown before you. And again, more hypopneas typical for a pediatric patient than in the adult population. So with that, if I could have the next slide, I believe we are ready to take any questions from the audience. Gary?
Thank you, Dr. Maneker, for your presentation. We have a couple questions submitted. Let me start with one on flow volume. This question asks, why does a flow volume pay more than spirometry, but is bundled within spirometry?
Yes, that's a great question. So when Medicare and all the other payers who adopt a Medicare-like fee schedule pay for a service, they pay for a typical characteristic service. And the vast majority of spirometry is going to be performed in patients for asthma, emphysema, interstitial or obstructive lung diseases, a broad range of pulmonary disorders in which the FEV1 and FVC and a brief glance at the flow volume loop is sufficient for the interpretation. The patient population in whom a flow volume loop alone is being obtained, of course, all the pulmonary physicians listening in will recognize that's the patient where the diagnosis of a fixed or variable extrathoracic airway obstruction, an upper airway obstruction, is under consideration. The pattern recognition for the changes in the appearance of a flow volume loop characteristic of either a variable or fixed upper airway obstruction need to be recognized. And it's technically more difficult than the routine garden variety review of a standard flow volume loop for the vast majority of patients. Medicare and other payers recognize that in this specific subset of patients in whom it's medically necessary to consider the diagnosis of a fixed or variable extrathoracic airway obstruction, that this service is valued higher because it's typically a more difficult patient and a more difficult test to interpret than spirometry. But in the routine patient undergoing spirometry, the look at the flow volume loop would be less intense and therefore valued slightly lower as a component of the routine spirometry.
Thank you. Our next question has to do with nitric oxide monitoring. What can I do to get reimbursed for exhaled nitric oxide if my local private payers won't cover it?
That's another excellent question, and the answer is negotiate, and be proud. Typically, most payers will consider what's called a carve-out or a contractual agreement to offer a service that is not typically reimbursed in their region. That would be a very specific contractual negotiated agreement, and it would typically be done in the context of a center of excellence. The discussion would be something along the lines of, I'm a premier physician in a premier practice taking better care than others in our region. This measurement will help me take better care of our patients, the patients I provide medical care and you provide insurance coverage to, and in the long run improve their health and reduce total costs to the system. and therefore I now want to be paid fairly for this medically necessary test. But the way to get paid is a private contractual negotiated agreement with each payer. It's very common for such practices who successfully negotiate these agreements to be considered a center of excellence and then have the payer try to send difficult asthmatics to those centers of excellence, if you will.
Okay, we have time for one more question. This one has to do with home sleep tests. What are the correct codes to report a home sleep test?
Okay, so the correct code for a home sleep test would be the 95806 unattended sleep study. That would be the correct code for it from the Medicare perspective. I am aware that there are certain payers in certain regions who still request claims carry the old codes that the 95806 replaced. Some of those were G codes, and before the G codes existed, there were actually T codes in existence. But in general, Medicare would recognize the 95806.
And that would be applicable to home sleep tests for children and adults?
Yes.
Okay. Well, Dr. Maneker, thank you for your time today, and thank you for the participants for listening to this webinar. And at this point, the webinar is now concluded.